talk to me? Are you choking?
Marty, okay?
I'm an emergency responder, man.
Make sure you keep your head still,
My name
okay?
is Cindy. I'm an emergency responder. May I help you?
Hello, my name is Tina. I'm at 5746. Can you hear me? My neighbor just collapsed.
Yes, there's been an accident.
Jimmy, come here quick. My name is Mason. Marty, Tina, I'm an emergency responder. May I help you?
My name is Eileen. I'm an emergency responder. May I help you?
Medical emergencies and accidents happen every day. They're an unfortunate but inevitable part of life. Usually, the first person to help is a layperson, just like you. By applying a few basic skills, this emergency responder can greatly increase the likelihood of a favorable outcome for the patient. You learn these basic skills in the Emergency First Response Primary Care, CPR, and Secondary Care First Aid courses.
Emergency First Response Primary Care, CPR, prepares you to aid patients with life-threatening emergencies. You learn the same emergency care priorities medical professionals use. Emergency First Response Secondary Care, First Aid, builds upon what you learn in the Primary Care course. In that course, you learn to give aid for medical emergencies that aren't immediately life-threatening. The Emergency First Response courses follow the protocols of the Basic Life Support Working Group of ILCOR, the International Liaison Committee on Resuscitation. This group represents the world's major resuscitation organizations. Although Emergency First Response is an internationally based course, local variation in skill technique, first aid procedures, terminology, requirements, and course flow may exist. Your Emergency First Response instructor will guide you. In Emergency First Response Primary Care, CPR, you learn 8 essential skills that link together when you help someone in a life-threatening emergency. Scene assessment, barrier use, primary assessment, rescue breathing, CPR, serious bleeding management, shock management, and spinal injury management. You may also learn other recommended primary care skills such as conscious choking adult, automated external defibrillators, or emergency oxygen use.
In Emergency First Response Secondary Care First Aid, you learn what to do when emergency medical services are either delayed or unavailable. Secondary care skills include injury assessment, illness assessment, bandage use, and splinting for dislocations and fractures. This video covers the skills for both courses. After watching the skills in the video, your instructor will demonstrate them for you in class. Then you'll practice the skills. After you've learned to perform and sequence the skills, you'll get to practice them in simulated emergency situations. This teaches you to adapt your emergency responder skills to real emergencies.
Are you okay?
A medical emergency arises. As an emergency responder, you know that if you assist, you can save or restore a patient's life. You can reduce a patient's recovery time.
Are you okay?
And you can make the difference between a temporary or lifelong disability. But even knowing this, sometimes people hesitate to help. Even people with CPR and first aid training, they may feel anxiety or guilt about the situation. Sometimes they're afraid they'll do the wrong thing. In some societies, people are afraid they'll get sued if the situation doesn't work out right. And there's the fear of HIV or other infection. As an emergency responder, realize that none of these concerns need prevent you from helping in a medical emergency. Let's look at why. The chain of survival represents the 7 links from a medical emergency to the patient's recovery. The first 3 involve you, the emergency responder. Link 1 is emergency recognition and scene assessment, followed by activating the emergency medical service. Then you begin emergency responder primary care. The 4th link is emergency medical service care, then hospital care. After care by the hospital, the 6th and 7th links are rehabilitation, during which the patient heals, and patient recovery. In a life-threatening emergency, the sooner emergency medical professionals arrive, the better the outlook for the patient. The emergency responder does not replace professional emergency medical care. In the chain of survival, your roles as the emergency responder are to summon emergency medical aid and to assist the patient until it arrives. Activating EMS is so important that in certain circumstances, if you're alone and there's no one else to activate the EMS for you, you call first, then assist the patient. An exception is if the patient is a child or an adult that has experienced submersion in water, cardiac arrest associated with serious traumatic injury, or suspected drug overdose. In these cases, you provide CPR for about a minute, then call emergency medical services. Keep in mind that your training as an emergency first responder pertains primarily to areas with readily available emergency medical services. If you're far from immediate help by either distance or time, you need further training in advanced first aid. As an emergency responder, you learn the basic steps and sequences for assisting another person. They're not difficult and come back easily when you need them, like riding a bicycle. So you need not fear helping in a medical emergency.
Your training also includes learning to use protective barriers to minimize the risk of disease transmission. By using barriers, you're highly unlikely to get any disease or infection from someone you help.
Many countries have Good Samaritan laws, which simply say that as a layperson helping another, you cannot be successfully sued if ultimately things don't work out well for the patient. Your training in this course will show you how to provide help within the protection of these laws. Good Samaritan laws will generally protect you if you only provide care within the scope of your training as an emergency responder. You act in good faith. You are not reckless or negligent. Act as a reasonably prudent person would. It's also important to ask permission to help a patient with a responder statement. You simply say, "Hello, my name is your name. I'm an emergency responder. May I help you?" It is important to get the patient's agreement if she is alert and responsive. If a patient is unresponsive and cannot answer, most laws assume implied consent. This means the law recognizes that the patient would accept help if she were able to do so. If an adult refuses your help, don't force it on her. Instead, talk to the person, stressing the need for care, and monitor her condition without providing actual aid. Depending on the situation, however, you could activate EMS at this time. The most serious medical emergency is when a patient isn't breathing and has no heartbeat. Sometimes people hesitate to help such a patient, fearing they'd make him worse. As an emergency responder, realize that you cannot make such a person worse.
Hey, Kev. Susie, go call for help.
Okay.
Hey, Kevin, are you all right? Kev, it's Steve. Can you hear me?
A person with no breath and no heartbeat is in the worst state of health. Again, remember you cannot make this person worse. But you may be able to help this person. You don't need to fear providing rescue breaths and chest compressions. You can trust your training. Take a moment to relax, think of your training, then step forward and help.
CPR helps to oxygenate the body when the heart isn't beating. You do this because if CPR begins soon enough and if emergency care arrives quickly, then it may be possible to restart the patient's heart.
CPR won't usually restart the patient's heart. Instead, it extends the period during which it may be possible to restart the heart.
Take it.
Todd, it's Richard. Todd, it's Richard.
Realize that CPR doesn't guarantee that the patient's heart will restart. In fact, most of the time, even with CPR, it doesn't restart. This means that you can never know whether providing CPR or any other aid that's called for would have made a difference unless you step forward and provide help. If you provide CPR and the patient's heart doesn't restart when medical care arrives, realize that you did everything humanly possible. But if you could have provided CPR and didn't, you may spend the rest of your life wondering whether it would have made a difference. Don't let that happen. Trust your training and help. Providing emergency care can be very stressful. After the incident and after the emergency medical professionals take over, it's time to take care of yourself. You may wish to talk about the event to a friend or to a family member. You may find the situation upsetting, especially if things didn't work out well for the patient.
Still, I feel like I let him down. I mean, what about his family? I feel like I let them down too.
Talk to someone if it helps, including a healthcare professional if necessary. But remember that as an emergency responder, your training only gives those you help the best chances possible, not promises nor guarantees of medical miracles. No matter how it works out for the patient, feel good about the fact that you reached out to help another.
Maybe you're right. Maybe doing something.
Your ability with any skill weakens when you don't use it for a while. But once you've learned it, it comes back much easier than learning it the first time. The more recently you practiced a skill, the easier it comes back. The same is true for your emergency first response skills. Hopefully, you won't need them often in real emergencies, so you want to practice to keep them fresh. Here's how. First, watch this video from time to time so you remember the skill steps and the information that relates to using them. Second, run through practice emergencies with other emergency responders in your family or among your friends. Try to get some CPR practice. If you don't have a CPR mannequin, use a stuffed sack that's the right size or even a pillow. But never practice CPR chest compressions on a person. Doing so can interfere with a person's normal heartbeat. Finally, refresh your skills with an instructor in the Emergency First Response Primary Care, CPR, and Secondary Care, First Aid Refresher, at least every 2 years. But refresh more often if you can. When you complete the update within 2 years of your previous course, you receive a current Emergency First Response completion card.
medical emergency, what's the first thing you do? It may surprise you that the first thing you do is think about yourself. You need to protect yourself. This is for the sake of the person needing help as well as for yours. After all, if you get hurt, you can't help.
Scene assessment is the process of looking for and avoiding any dangers at the scene of a medical emergency. It's the first thing you do and the first skill you'll practice. Scene assessment takes 3 steps. 1. Stop. 2. Think. And then 3. Act.
Stop and assess the scene for hazards. What hurt the person? Can it hurt you? Watch out for traffic, especially if helping around an auto accident. Be wary of the unseen, like fumes, electricity sources, chemicals, or radiation. Beware of spreading fire, not just because it burns, but because smoke inhalation can injure, incapacitate, and even kill. After you're sure the scene is safe, take a moment to think about what to do next. After surveying the scene quickly, ask yourself, what emergency care might be needed? If there's more than one patient, who appears to need help the most urgently? What can you reasonably expect to do? How do you activate emergency medical service where you are? Now, act. In a readily apparent serious emergency, first activate the local emergency medical service, either yourself or by having an able bystander do so. If you make the call, it's best to stay on the line until you hear the emergency operator hang up. That way, you won't accidentally hang up before the operator gets all the necessary information. In some circumstances, the need for medical care may be in question, so you would activate the emergency medical service after or during your primary assessment based on what you find. As you help, follow the emergency first response skill sequence. But scene assessment and taking care of yourself never stops. Ensure your safety so you can help others in need. Earlier, you learned that some people fear infection and therefore hesitate to help others in medical emergencies. The diseases of most concern are those transmitted through blood and other body fluids. These are hepatitis B and C and human immunodeficiency virus, or HIV. As an emergency responder, you can greatly reduce infection risk by using gloves and by using ventilation masks or shields. You can minimize the risk of infection by always placing a barrier between you and any body fluid of another person.
Like scene assessment, barrier use is a skill that usually comes before you start helping the patient. Remember to start with skill 1, scene assessment. Stop, think, and act. First, you'll put on gloves. Put the glove on carefully to avoid tearing. Because gloves are relatively delicate, you may want to wear more than one pair in any situation in which you might easily tear one, such as assisting an injured patient around broken glass. Remove gloves so that you don't spray or spread body fluids. Carefully loosen the first glove at the wrist and roll it inside out into a ball. Hold it in your gloved hand, then roll off the remaining glove by lifting at the wrist from inside, like this. Use caution not to tear the gloves or snap them, which can spray body fluids. Place the gloves in a biohazard bag for disposal according to local guidelines. Your instructor will show you how to use one or more of the different ventilation barriers available. They all trap or isolate you from moisture or fluids from the patient's breath and mouth, allowing you to provide rescue breathing and CPR with minimal infection risk.
Barriers take up little room, so it's easy to keep a set of gloves and ventilation barriers handy. Try to keep one or more sets so they're nearby at all times. But they're not required to provide CPR. The risk of infection is minimal and may be even lower if you're helping someone who has a medical history you know, like a family member. This is your decision, but you may decide you don't need to withhold aid just because you don't have a barrier available. It's reassuring to know that there's never been a documented case of an injured or ill person infecting a CPR provider with hepatitis B or C or with HIV. You've assessed the scene, activated the local emergency medical service, and donned your barriers. Now you're ready to begin primary assessment. Primary means first and most important. Primary assessment is your first and most important evaluation of the patient. During the assessment, you evaluate the patient for life-threatening conditions that need immediate attention, and you determine the priorities you need to follow. Have you ever wondered how medical professionals know what to treat first when they help someone? They monitor the ABCDs of the patient's lifeline, which provide the sequence for helping the patient. You'll practice monitoring the lifeline and the ABCDs as you learn emergency first response skills.
A stands for assess the scene. Alert the emergency medical service and assure the airway is open so the patient can breathe. B means breathing check and begin rescue breathing if necessary. C tells you to check for signs of circulation and begin chest compressions if there aren't any. D is defibrillation, the process that attempts to restart the heart. You'll learn more about defibrillation a bit later. S reminds you to apply serious bleeding management, shock management, and spinal injury management.
No matter what the patient's situation when you arrive, you begin with primary assessment following the ABCDs of the patient's lifeline. Throughout the incident, you continually monitor the lifeline, ready to provide assistance based on what it tells you. Watch this emergency scenario, noting how the ABCDs guide the rescuer. After the scenario, we'll review how the rescuer applied each step.
Marty, are you okay? Marty, it's Tina. I'm an emergency responder. May I help you? Marty! Marty! Hello, my name is Tina. I'm at 5746 Michael Street. Yeah, my neighbor just collapsed. Can you please send someone over? Thank you. 7, 8, and 9, and 10, 11, 12, 13, 14, 15. Two and 3 and 4 and 5 and 6 and 7, 8 and 9 and 10, 11, 12, 13, 14, 15.
The Lifeline ABCDs answer all questions about what conditions to treat first. For instance, suppose a patient has serious bleeding and no signs of circulation. What do you do first? First, you go to A and assess the scene.
Hi,
Alert EMS
I'm at 5.
and open the airway. Then you go to B and check for breathing. You find the patient isn't breathing and give 2 rescue breaths. At step C, for circulation, you find the patient's heart isn't beating and begin chest compressions. Rescue breaths and chest compressions take priority over serious bleeding. The Lifeline ABCDs lead you correctly to deal with the absent heartbeat before you deal with serious bleeding.
Let's look at primary assessment first with a responsive patient, and then with an unresponsive patient. A responsive patient is one who is alert and able to answer questions. Begin with assess the scene. Stop, think, and act. Sometimes you can don your gloves as you approach the patient. Next, give the responder statement, "Hello, my name is," your name. "I'm an emergency responder. May I help you?"
My name is Robin. I'm an emergency responder. May I help you?
Do not move the patient unless there's an immediate threat to you or the patient's safety. Because this patient is responsive and talking, you verified the airway, breathing, and circulation of her lifeline. Check for and treat serious bleeding, treat for shock, and treat for spinal injury, again without moving the patient. As you monitor the lifeline, alert the emergency medical service if and when you find any serious medical condition. Now let's look at primary assessment with an unresponsive patient. An unresponsive patient is one who is either completely unconscious or one who may be partly conscious but incapable of rational responses. Begin with assessing the scene. Stop, think, and act. Put on your gloves. Perform your assessment with the patient in the position you find him. First, give the responder statement.
Hello? My name is Eileen. I'm an emergency responder. May I help you?
You do this even with an unresponsive patient because he may still be able to hear you.
Hello?
If the patient doesn't respond to your statement, then tap him on the shoulder to further check responsiveness.
Are you
While
okay?
tapping the patient,
Are
you may
you
ask,
okay?
"Are you okay?"
Are you okay?
The patient does not respond, so have someone alert the emergency medical service or do it yourself if you're alone. Open the airway using the head tilt chin lift. While lifting the bony part of his chin with your fingertips, put your hand on the patient's forehead and gently tilt his head back, like this. If you suspect neck injury, use only the chin lift, like this. Do not tilt the head or turn it from side to side. Hold the airway open and conduct a breathing check. Look, listen, and feel. Watch for the chest to rise and fall. Listen for breathing and try to feel his breath on your ear. Do this for about 10 seconds. This patient is breathing, so move on to C, circulation. If the patient were not breathing, you would perform a circulation check to look for signs of blood circulation. You'll learn the details for this when you learn skill 5, One Rescuer Adult CPR. This patient has a heartbeat and circulation, so D, defibrillation, to attempt to restart the heart isn't necessary. If it were, Emergency medical personnel would attempt this when they arrive, or you may use an automated external defibrillator if available. You may learn more about these as you learn the emergency first response skills. Finally, you would check for and treat serious bleeding, shock, and spinal injury. After your primary assessment, you normally put a breathing, unresponsive patient in the recovery position. This decreases the risk of something blocking her airway and allows fluids to drain should she vomit. Keep the patient's head stable, in line with her body. This way, if there's an undetected spinal injury, you won't make it worse. Put the patient on her side. Put her lower arm near or under her head to keep her head in place. Use her upper leg to hold her in place. Continue to monitor her lifeline.
If during your primary assessment you discover that the patient isn't breathing, you'll use rescue breathing. Rescue breathing uses your breath to inflate the patient's lungs and provide oxygen. This works because we use only a small portion of the oxygen in each breath we take, leaving ample oxygen to support life. Rescue breathing is so effective that you can continue it for hours, provided the patient has a heartbeat.
As you've learned, you follow the ABCDs of the lifeline. Begin with assessing the scene. Stop, think, and act. Don your barriers. Next, give the responder statement.
My name is Mason. I'm an emergency responder. May I help you?
If the patient doesn't respond to your statement, then tap her on the shoulder and ask,
Are you okay?
if the patient does not respond, have someone call the emergency medical service,
Call for help.
or do so yourself if you're alone. Open the airway using the head tilt chin lift. If you suspect possible neck injury, use the chin lift only. Look, listen, and feel for breathing up to 10 seconds. If the patient isn't breathing, put her on her back if she's not already in that position. Remove any obstructions like dentures or gum from her mouth. Put the ventilation barrier in place as you've already learned. Pinch or block the patient's nose closed. Give 2 slow rescue breaths. Blow steadily into the patient's mouth, just enough to cause the chest to rise. After 2 slow breaths, perform a circulation check. You'll learn how to do this in a moment. It is important to note at this point that adult patients who are not breathing more than likely do not have a heartbeat. You will probably have to perform CPR as well. If the patient does begin to breathe on her own, continue to help the patient and maintain an open airway. Place her in the recovery position and continue to monitor her lifeline. If you cannot inflate the patient's lungs, recheck the airway for obstructions and proper position and try again. Improper position is the most common cause for a blocked airway. Try up to 5 times to give 2 breaths. Check for obstructions and open the airway. If you cannot inflate the patient's lungs after 5 times, you will begin CPR, which is the next skill you'll learn. If the patient has a mouth or jaw injury that may interfere with rescue breathing, gently hold the patient's mouth closed. Reposition your barrier over the patient's nose and give rescue breaths through the nose. Some barriers allow you to do this without repositioning them, and some may not work for on the nose at all.
Individuals in cardiac arrest do not breathe. However, some may gasp irregularly. This may seem like the patient is breathing. These are called agonal breaths. Agonal breaths sound something like this. Mistaking agonal breaths for actual breathing could mean not giving CPR and rescue breaths when you should. Therefore, it's important not to confuse agonal breaths with normal breathing.
If you find no signs of circulation when you make a circulation check, you will need to begin CPR chest compressions. This is the next skill you'll learn.
In the section on rescue breathing, you learned that if the patient doesn't have a heartbeat, you use CPR or cardiopulmonary resuscitation to circulate the patient's blood. CPR combines rescue breathing and chest compressions. If the heart isn't beating, rescue breaths alone don't benefit the patient.
Chest compressions work by moving blood with oxygen through the body to vital organs, even when the heart has stopped.
CPR is an emergency measure that can extend the window during which it may be possible to restart the heart. However, it only circulates about 1/3 as much blood as the heart, and it's difficult to sustain for long periods. Even with CPR, the sooner one attempts to restart the heart, the more likely it will restart. This is why it's important that emergency medical personnel arrive quickly and provide advanced cardiac life support, such as drugs, artificial airways, ventilation devices, and defibrillation.
Defibrillation is the process of restarting an erratic heart. Natural electrical impulses control your heartbeat. When these impulses fail, the heart beats erratically and no longer pumps blood. This is called fibrillation or twitching. Defibrillation administers a shock that momentarily disrupts the erratic signals and allows the normal heartbeat to return. As time passes, the probability of defibrillation restoring the heartbeat goes down. It is rare for a heart to resume beating without defibrillation, even with CPR. This is why you contact the emergency medical service first if you're alone and don't have someone else there to do it for you.
The benefit of prompt defibrillation was the reason for the development of automated external defibrillators, or AEDs. AEDs are defibrillators designed for use by lay emergency responders. AEDs electronically monitor the need for and administer a shock. Your instructor may provide AED instruction as part of this course.
I'm clear, you're clear, everybody's clear.
Shock now.
You will practice CPR using a CPR mannequin. Remember, do not perform chest compressions on someone who does not need CPR. Again, the ABCDs of the lifeline tell you where to start. Begin by assessing the scene. Stop, think, and act. Next, give the responder statement.
My name is Eileen. I'm an emergency responder. May I help you?
If the patient doesn't respond to your statement, then tap him on the shoulder and ask,
Are you okay? Are you okay?
alert the emergency medical service, then open the airway as you've already learned. Check for breathing. If the patient is breathing, then he also has a heartbeat. This patient isn't breathing, so follow your rescue breathing training and give 2 slow rescue breaths. After the 2 breaths, you will perform a circulation check. Remember, most adults who are not breathing also do not have a heartbeat. However, to further confirm that a patient's heart is not beating, perform a circulation check by listening again for breathing or coughing. Second, look the patient over for movement. If there's no breathing or movement, assume his heart is not beating. You will need to begin chest compressions. Move to the patient's side like this. Next, you would remove apparel to expose the chest. For the purpose of this video, often the chest will not be exposed. To find the compression site, follow the edge of the ribs up to the center. You will feel a notch at the lower end of the breastbone. Put your middle finger and index finger on this notch and, keeping your fingers there, put the heel of your other hand on the breastbone next to them. Put the hand from the notch on top and interlock your fingers, like this. If you forget this technique or have trouble with it, just put the heel of your hand in the chest's center, between the nipples. Position yourself so you're directly over your hands with your arms straight. Then press down on the breastbone with enough force to depress it 4 to 5 centimeters, or 1.5 to 2 inches. Release and repeat for 15 compressions. The pace is fast, like this.
1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10, 11, 12, 13, 14, 15.
This fast pace is about 100 compressions per minute. Now reopen the patient's airway and administer 2 slow rescue breaths. Follow this with finding the compression site and giving 15 more compressions. After approximately 1 minute of CPR, or 4 sets of 15 compressions and 2 breaths, give the patient a circulation check. If there's still no movement or breathing, continue CPR until EMS arrives, until you can defibrillate with an AED if available and allowable, until the patient shows signs of circulation, or until you're too exhausted to continue.
April. April, I'm an emergency responder. May I help you? Are you okay, April?
Is there anything I can do?
Call for help. April. April, this is Gwendolyn. Are you okay?
An unresponsive patient may have an obstructed airway and you can't give 2 slow rescue breaths to this patient. This may be because a choking patient loses consciousness or because of an unknown obstruction. If you cannot give 2 effective rescue breaths after checking for obstructions and trying to open the airway 5 times, move immediately to chest compressions. The CPR thrusts should dislodge any obstruction. Each time you open the airway, look for something blocking it in the back of the throat. If you see something, remove it. This is the only time you might give chest compressions to an unresponsive patient with signs of circulation.
Greg cut himself on the saw. Can you call for help and wait outside for them till they get here and bring him back?
Okay.
Thanks.
Can I help with anything?
Yeah, could you get the first aid kit, please?
Yeah.
Thank you. Okay, Greg, try and elevate him from here. Okay, try and keep your arm elevated here. Great, thanks. Great. Keep the area. Thanks. Okay, Greg. Get this on here. Anything, Greg?
The S of the Lifeline's A, B, C, Ds prompts you that after confirming the airway, breathing, circulation, and defibrillation if needed, you need to control serious bleeding. Serious bleeding can be life-threatening because blood carries oxygen to the body tissues. The body holds about 6 liters or quarts of blood. Losing even one can cause death.
There are 3 types of bleeding depending on the type of blood vessel injured. Arteries are the largest vessels and carry blood from the heart to the tissues. Arterial blood spurts with each heartbeat and is bright red. Arterial bleeding is the most serious because the patient can lose a lot of blood quickly. Call the emergency medical service immediately for this type of bleeding. Veins lead from the tissues back to the heart. Venous blood is dark and flows steadily without spurts. Venous bleeding can also be life-threatening. If you cannot control it, contact the emergency medical service and monitor the patient's lifeline. Capillaries are tiny blood vessels between the arteries and veins where the blood and tissues exchange oxygen. Capillary bleeding tends to be slow and easily controlled, unless the injury covers a large area. Monitor the patient's lifeline and contact the emergency medical service if necessary. Assess the scene, stop, think, and then act. Next, put on your barriers, tell the patient that you're an emergency responder and ask if you can help. When the patient says yes, call emergency medical services.
Go call for help.
Since the patient is responsive, you have confirmed the patient has an airway, breathing, and circulation. Serious bleeding is usually obvious. Control the bleeding by using direct pressure. Put a clean cloth or dressing on the wound and apply pressure. If you have no dressing, use a piece of cloth or even just your gloved hand if there's nothing available. Maintain the pressure continuously, but you may periodically release pressure to see if the bleeding has slowed or stopped. It may help to elevate the wound to reduce blood flow to it. In addition to direct pressure, you may also use a pressure bandage. While maintaining direct pressure, tie another dressing over the initial one. The patient may assist if able. If the dressing becomes blood-soaked, don't remove it. Instead, add another on top and continue direct pressure. Do not remove blood-soaked dressings. Blood will clot in the dressing and slow or stop bleeding. Removing the bandages will disrupt this process. If direct pressure and a pressure bandage don't stop bleeding, you may also use a pressure point. A pressure point is a place where an artery runs over a bone. This chart shows the key pressure points to control bleeding in the arms and legs. While still maintaining direct pressure and elevating the wound, apply pressure to the pressure point with your fingers, thumb, or heel of your hand. This restricts flow through the artery to help control bleeding.
Shock is the body's response to serious injury or illness. It can be life-threatening and happens when not enough oxygenated blood reaches the body tissues. There may be too little blood because of serious bleeding, or it can happen when the body no longer regulates blood flow to the tissues. In shock, the tissues don't get enough oxygen. 9 signs and symptoms indicate shock, though some occur with other injuries. They are mental confusion, anxiety, restlessness or irritability, altered consciousness, pale or bluish tissue, rapid weak pulse, shallow but rapid labored breathing, nausea, vomiting, thirst, lackluster eyes, dazed look, and moist, clammy skin, sometimes with shivering.
By the time you get to shock management, you will have progressed well along the patient's lifeline. You will have assessed the scene and put on your barriers. Through primary assessment, you would have alerted the emergency medical service and confirmed airway, breathing, and circulation. There would be no need for defibrillation, or you would be providing CPR, and you would have handled serious bleeding. To treat shock, if the patient is responsive and you don't suspect head, back, or neck injury, put the patient in a comfortable position. If there may be head, back, or neck injury, don't move the patient and keep his head and neck immobile. In either case, cover or shade the patient to maintain his normal body temperature. If you've had to control serious bleeding, maintain control of the bleeding. If there's no reason to suspect head, back, or neck injury, elevate the patient's legs 15 to 30 centimeters, 6 to 12 inches. This shifts blood to the more critical chest and head areas. If oxygen is available, it can help a patient in shock. Some units are easy to use and require little, if any, training.
Spinal cord injuries can cause permanent paralysis or death. The spinal cord runs through the neck, down the back, and connects the brain to the rest of the body's nervous system. A break in the spinal cord makes it difficult for the brain to control the nervous system below the break. Injuries to the head, neck, or spine may injure or threaten the spinal cord. Moving a patient with a head, neck, or spine injury may make the injuries worse. Therefore, never move a patient with a suspected spinal injury unless absolutely necessary because of imminent danger. Conduct your primary assessment where you find the patient. You would only move the patient to avoid immediate further harm, such as if the patient were in the water or a burning car or building. You would also move the patient, if necessary, to provide rescue breaths and/or CPR compressions. You should suspect spinal injury with situations that cause injury to the head, neck, or spine. These include auto accidents, being thrown from a moving object, falling, especially from a height higher than the victim, a penetration wound, such as a gunshot, any severe blow to the head, neck, or back, an accident that involves hitting something head first, such as diving into shallow water, lightning strike, or any severe impact injury, regardless of what part of the body was struck. 8 indications that a patient may have a spinal injury are change of consciousness, difficulty breathing, vision problems, inability to move some or all of the body, paralysis, headache, vomiting, loss of balance, tingling or numbness in the extremities.
Following the ABCDs of the lifeline, start with scene assessment. Conduct your primary assessment with the patient in the position you find her, unless patient safety is in question or her lifeline is in jeopardy. Meaning you need to open the airway, deliver CPR, or control serious bleeding. Put on your barriers and contact emergency medical services.
Call for help.
The patient must be on her back for rescue breathing. If she's not already on her back, you have to turn her while minimizing risk to her spinal cord. You want to stabilize the head and neck so that as you turn the patient, they stay aligned and unmoved relative to the spinal column. If you have someone who can help, have him hold and stabilize the head as you roll the patient all at once, keeping the head, neck, and spine together as a unit. If you're alone, you'll stabilize the head yourself. The log roll technique helps you do this. Tuck the arm away from you, under her hip, and while supporting her head, roll the patient toward you. Gently ease the patient onto her back and continue with the ABCDs by opening the airway, rechecking for breathing and circulation, and then supplying rescue breaths and CPR as necessary.
During your primary care course, your instructor may also have you practice one or more of the recommended primary care skills: automated external defibrillator, conscious choking adult, and emergency oxygen use. Depending on local guidelines, restrictions, or laws, your emergency first response instructor may or may not be able to offer a skill development session on these recommended primary care skills. Now that you understand the 8 primary care skills, let's apply them to some realistic situations. Watch as the emergency responder in each scenario adapts the lifeline A, B, C, Ds to the realities of the situation.
Grandma? Are you okay? What happened? What's wrong? What happened? Hang on, everything's gonna be okay.
Stop, think, and then act. Is there a hazard here? The emergency responder sniffs for gas and confirms that the gas stove is turned off.
Grandma, do you need help? It's okay, I'm an emergency responder. May I help you? Jimmy, come here quick! It's okay. What's wrong? I don't know. Something's wrong with Grandma. Go call for help. Tell them we have an emergency and then come back and tell me what they say. I'll call and come back. It's okay, Grandma.
The emergency responder gives the medical statement and gets emergency care on the way. The emergency responder monitors the patient's lifeline. She's breathing, confirming airway, breathing, and circulation. There's no evidence of bleeding.
Help will be here soon. Help me put her in the recovery position. Put her leg a little bit forward. Go get the pillow and blanket on the couch. Go wait for the ambulance outside.
The emergency responder treats for shock and continues to monitor the patient's lifeline until help arrives.
Help is on the way, don't worry. Dawn? Dawn, are you okay?
The emergency responder stops, assesses the scene, thinks, and then acts.
Dawn, this is Emily. Are you okay? Dawn, I'm an emergency responder. May I help you? Dawn! Dawn, are you okay? Front desk, this is Emily. I'm in Dawn's office and there's a medical emergency. I need you to contact the emergency medical service. No, I can manage. It's more important that you wait for the paramedics and bring them directly here. Okay, bye. Dawn, are you okay? I'm an emergency responder. May I help you? Don, are you okay?
The emergency responder finds the patient isn't breathing and turns her so she can give rescue breaths. The patient shows no signs of circulation. The emergency responder provides rescue breaths and chest compressions, repeating the circulation check and breathing check about every minute until emergency medical personnel arrive and attempt defibrillation.
Hey, you're doing a great job. Just keep on going while we get set up.
How long has she been down?
10 minutes.
Do you know anything about her medical history?
I don't.
Do you know how old she is?
I don't know.
A medical emergency with more than one victim and only one emergency responder requires some thought. You can only do so much, so do the best you can. Stop, think, and then act.
Yeah, I need to report an auto accident on the corner of Alton and Pacific. It looks like you might have a couple injured passengers. Yeah. Yeah, okay. Sit tight, all right? Help's on the way.
The emergency responder approaches the scene cautiously, keeping himself safe and watching for hazards as he approaches the scene.
Hey, my name's Matt. I'm an emergency responder. May I help you?
Yes.
Well, where do you hurt?
On my head. I'm okay.
All right, listen, I want you to try not to move your head and neck until the medical crew gets here, all right, so they can check you out.
Okay.
Okay? Help's on its way. I'm gonna go take a look at your passenger. She looks like she might need some attention, so I'll be nearby. Just sit tight and relax, all right?
All right.
Okay. Hey, how you doing? You okay? You okay? Try not to move, all right? Lay still.
The emergency responder follows the second patient's lifeline and controls serious bleeding. Notice that he continues to monitor the ABC parts of the lifeline while maintaining pressure on the wound.
How's your head feel?
The same.
Okay, just relax. Help's on its way.
The emergency responder asks the question as a simple way of checking the first patient's lifeline.
Is there anything that I can do?
Are you a trained emergency responder?
No.
That's okay. You know what? You can put on this extra pair of gloves I have here.
Okay.
Try and lay still, okay? Keep your head still for me. What I need you to do is I need you to put pressure on this wound here, okay? If you need another bandage, go ahead and take one out of that box and put it right on top of this, all right? Keep pressure on the wound the whole time. Okay, so when I take my hands off, go ahead and replace them with yours, okay? Here we go. Good.
The emergency responder continues to monitor the ABCDs for both patients until the emergency medical service providers arrive.
There you go, lay still. Okay, keep pressure on there.
Okay.
Okay, try and relax, okay? I'm gonna hold your head until the ambulance gets here.
All right.
Sit tight, all right? The guys are here.
How many people do we have in the vehicle? One?
Just two.
Two, that's it? Anyone ejected? Anyone else in the vehicle? No?
Came on these guys.
No, that's it. Okay, what do you have right there?
As you saw, having more than one person at the scene increases the aid available. By encouraging your family and friends to complete the emergency first response courses, you increase the chances there will be more than one emergency responder at hand in a medical emergency.
As an emergency responder, you play a crucial role in a medical emergency. In life-threatening emergencies, you're the critical first link in the chain of survival that summons emergency medical aid and monitors the patient's lifeline, providing aid that increases the chance of survival or revival. In emergencies that are not immediately life-threatening, you provide comfort and reduce the risk of permanent disability. Most emergency responders will never need their skill, but practicing them and reviewing this tape will help you be ready to reach out and help another in need, should you ever need to. Now that you've completed Emergency First Response Primary Care, you're ready to complete the Secondary Care course. As you recall, this is secondary care because it follows the primary care of assuring the ABCDs of the patient's lifeline. And, as you recall, primary care never stops. You constantly monitor the patient's lifeline. However, if emergency medical services are either delayed or unavailable, you'll need the following secondary care skills. You'll practice 4 secondary skills: injury assessment, illness assessment, bandaging, and splinting for dislocations and fractures.
Injury assessment helps you identify injuries that affect the patient. You can attend to some of the injuries and you will report them to emergency medical personnel once they arrive.
Remember that you always begin with primary care and the ABCDs. Assess the scene, stop, think, and then act. Use gloves and barriers, check for patient responsiveness, and give your responder statement. Contact the local emergency medical service if possible or needed.
My name is Eileen. I'm an emergency responder. May I help you? Okay, let's call for some help.
Be sure that you don't need to attend to anything on the patient's lifeline before beginning the secondary injury assessment. Start by telling the patient that you're going to check for injuries. Hold the patient's head and ask the patient to keep her head still and answer questions verbally rather than nodding or shaking her head. It helps to ask questions that she can't answer with a yes or no. You start your assessment at the head and work to the patient's toes. If the patient complains of head, neck, or back pain, stop the assessment immediately and keep the patient immobile until help arrives. Feel for deformities on the patient's face with a gentle touch. Check the ears and nose for blood or fluid. See if the patient's pupils are the same size, and have her follow your finger with her eyes, without moving her head or neck. Check the eyes for smooth tracking. The eyes should track together. Also check pupil size. Feel the skull and neck for abnormalities. If the patient complains or you find something, stop the assessment. Slide your hands over the shoulder blades and gently push against the back. Press inward on the shoulders and run your fingers over the collarbones to the center. As you perform these steps, you're looking for irregularities or blood, or for the patient to mention pain or other unusual sensations caused by your touch. Stabilize the patient's arm with a hand on the shoulder and slide your hand gently down the upper arm, elbow, and wrist. Repeat on the other arm. Ask the patient to wiggle her fingers on both hands and squeeze yours to check for paralysis or weakness. Inspect the chest for deformity. Place a hand, palm in, on each side of the patient's rib cage and gently push inwards. Gently put your hands under the patient to check the spinal column. Cover as much area as possible without moving her. If you find any irregularities, stop the assessment. Ask the patient to tell you if she feels pain. Gently push on the patient's abdomen, on the right, left, and above and below the navel. Move your hands over the hip bones, palm inward, and gently push on the hips. Starting at the thigh, slide a hand down the upper leg, knee, lower leg, and ankle. Ask the patient to wiggle her toes and press her foot against your hand. Repeat this with the other leg.
After your assessment, you will attend to the injuries you can. Otherwise, continue to monitor the patient's lifeline and report what you found during the assessment to emergency medical services personnel. Illness assessment helps you find and report medical problems that affect the patient's health and may aid with treatment. You'll assess the patient by asking questions and by checking the patient's breathing, pulse, temperature, and skin.
In class with your instructor, you'll practice an illness assessment on a healthy person. Assessing a healthy person may help you recognize differences later if you assist an unhealthy person. As you've learned, you start with primary assessment. After giving the responder statement and assuring the patient's lifeline, get something to write on so you or someone assisting you can record what you find. There is an illness assessment record sheet in your participant manual. To help you remember how to begin an illness assessment, use the mnemonic SAMPLE. SAMPLE stands for signs and symptoms, allergies, medications, pre-existing medical history, last meal, and events. The S stands for signs and symptoms. Signs are something you, the rescuer, sees. Symptoms are something the patient tells you he's feeling. Ask the patient how he feels and what happened right before getting ill. Ask, how do you feel now? Next, you'll check the patient's pulse. Find the pulse on the patient's wrist. Feel the pulse with your fingers, not your thumb, and count for 30 seconds. Then multiply by 2. The typical adult pulse rate at rest is 60 to 80 beats per minute. Next, you'll check the patient's respiration. As you do this, remember that the typical adult breathing rate at rest is 12 to 20 breaths per minute. Someone breathing markedly faster or slower may have a medical problem. To check the breathing rate, watch the patient's chest or place a hand on it while timing for 30 seconds, then multiplying by 2. Attempt to check a patient's respirations without them knowing you are doing so. Listen for wheezing, gurgling, or high-pitched noises. Note if the patient complains of short breath, dizziness, lightheadedness, chest pain or numbness, or tingling in the arms or legs. Next, check the patient's temperature and moisture. Feel the patient's forehead with the back of your hand. See if it's warm, hot, cool, moist, clammy, etc. Check the patient's color. Is it pale, ashen, reddish, bluish, or yellowish? Does it have blotches? If the patient has dark skin, check for color change in the nail beds, lips, gums, tongue, palms, whites of the eyes, and earlobes. Usually, an adult at rest should have skin that's warm and dry to the touch. Noticeable changes in temperature, moisture, and color may indicate problems. Next, check the patient's pupils. Are they enlarged? Small? Unequal? Any of these may indicate problems. Also in the mnemonic sample, the A stands for allergies. Ask the patient about allergies to medications, insects, food, or the like. Ask the patient, have you been exposed to something you are allergic to? While talking to the patient, look for Medic Alert bracelets. Next, the M stands for medications. Ask the patient if he takes any medications. If so, ask, what medication do you take? Did you take it today? How much did you take and when? If possible, get the patient's medication so you can turn it over to emergency medical personnel when they arrive. The P in sample stands for pre-existing medical history. Ask the patient if he has any medical conditions, like asthma, epilepsy, heart conditions, or diabetes. The L in sample stands for last meal. Ask the patient, when did you last eat? What did you eat? The E in sample stands for events. Ask the patient about or note the events that led up to the illness.
Bandaging helps control bleeding, immobilize the injury, and reduce dirt or other contaminants from entering a wound. It's a skill that can range from life-saving in the case of serious bleeding to simply helping the patient feel more comfortable.
After attending to primary care and injury assessment, you may apply roller bandages directly over sterile dressing on a wound. As you recall, once you have a dressing in place, you don't remove it. Start below the wound and wrap upward over it. Wrap tightly enough to hold the bandage snugly in place, but loose enough that it doesn't restrict circulation. Leave fingers and toes exposed so you can check them for proper circulation. If you're bandaging a foot, start with a couple turns around the ankle, then over the injury site on the foot. Similarly, start a hand bandage around the thumb and wrist. Elbow and knee injuries normally call for wrapping above and below the joint to stabilize the injury. Triangle bandages support injuries to the arm, ribs, or shoulder. Start with the bandage top over the shoulder on the affected side. Bring the arm over the bandage, then bring the low end of the bandage up behind the neck and tie it off. Support the arm and hand with the fingers showing. If you suspect broken ribs, tie a second bandage to hold the arm against the injury side of the chest. This helps immobilize the entire affected side of the torso.
Splinting immobilizes broken bones and dislocations. This reduces the risk of further injury and serious bleeding and lessens pain for the patient. You may need to apply a splint if emergency medical care is either delayed or unavailable.
When needed, splinting follows all primary care concerns, injury assessment, and any necessary bandaging. Splint the injury in the position you find it. Don't try to straighten it, and try to minimize moving the affected limb before you splint it. You can use a commercial splint or improvise with almost anything rigid. Choose a splint long enough to immobilize joints above and below the injury. Pad the splint with extra padding inside body curves and hollows for even, comfortable contact with the splint. Bandage the splint in place using a roller bandage, adhesive tape, or other material available. It should be snug enough to immobilize the injury, but not restrict circulation. Check the pulse before and after splinting for blood flow. Gently squeeze the patient's fingertips or toes and check that the nail beds immediately regain their color. If not, or there's no pulse, loosen the bandages so normal circulation returns. If the fracture involves an arm, you can put the arm in a triangle bandage after splinting. One important point: do not splint if doing so increases patient discomfort or pain.
Now that you understand the 4 secondary emergency first response skills, let's apply them to some realistic situations. Note in each scenario that the emergency responder first attends to the lifeline ABCDs and confirms that EMS is either delayed or unavailable before moving into secondary skills. The emergency responder takes a moment to assess the scene. He stops, thinks, and then acts.
Hey there. Looks like you took a little spill. My name's Pat Jones. I'm an emergency responder. May I help you?
Yeah, I think I broke my arm.
Yeah, anything else?
Because the patient is responsive and talking, the emergency responder knows that the patient has an open airway, is breathing, and has a pulse.
Okay, just relax and try not to move, okay? While I try and get help.
Okay.
No service. Guess I won't be able to get emergency medical services here, but it's okay. I can assist you. Try not to move your head at all.
Okay, all right.
Let me take off your glasses, okay?
All right.
You doing okay?
Yeah.
All right, open your eyes and try not to move your head while you look at my finger. Perfect. Let me check your ears for you. How's your head feel?
It feels good.
Any pain when I'm feeling this?
No.
What about back here? Nothing?
That's fine, that's fine.
Okay, how do your shoulders feel?
I feel okay.
Okay. Any pain?
No.
Nothing?
No.
Okay, how you doing, okay?
Okay.
Don't move your head. How's that feel?
That's okay.
I'm gonna check your spine for you, okay? Tell me if you have any signs of pain. Anything?
No.
Okay. And check your abdomen now. Does that hurt?
No.
Here?
No.
Here?
That's okay.
Here?
It's good.
Okay, I'm gonna check your hips. How's that feel?
It's okay.
All right, I'm gonna go down to your legs now. Feel any pain here?
No.
Anything?
No.
Wiggle your toes for me. Okay, let's do the other side. How's that feel?
Feels good.
Can you wiggle your toes for me? Okay, which arm hurts?
It's my right arm.
Okay, I'm gonna leave that alone for now, and I'm gonna bandage this cut first. Then I'm gonna splint your other arm, okay? That should make you more comfortable, all right?
Okay.
Let me get the splint. I'll be right back. I got a blanket for your head, okay? Let's move this out of the way. I'm gonna easily move up your head. Okay, lift it up slightly. Okay, set it down. How's that feel?
That's okay. It's good.
Okay.
It's good.
Let me see. Let me see this arm. Try not to move your head, okay?
All right.
All right. So what were you doing out this morning? Just going for a bike ride?
Yeah.
Yeah? What'd you do, hit a rock, didn't see it or something?
I don't know.
Yeah. This should make you feel a bit better, okay, buddy? What's your name?
Eric.
Yeah? How you feeling?
It's just my arm, man.
Yeah. Looks like you took a little bad spill on that side. I'll get to it in just a second, okay? Doing okay?
Yeah.
All right. Just about done here. Okay, I'm gonna splint your arm now, okay? You help by moving your wrist area, and I'm gonna move your elbow up, and I'm gonna slide the splint underneath your arm, okay? At the count of 3. 1, 2, 3. I know it hurts. This will make it feel more comfortable. Good. Let's move it across your chest slightly. Okay, I'm gonna tie the splint now, okay? You doing okay?
Yeah, yeah.
All right, I know this hurts, but it will feel better. All right. Look, we're pretty far away from emergency medical services, okay? And I can't get any service down here. I can take you, or I could go get help. I think it'd be fastest if you come with me. Are you comfortable with that?
Carrie, are you okay?
Oh, hi, Marino. Just something I ate.
Well, you don't look well at all. Look, I'm an emergency responder. Can I help by taking your pulse and other things just in case?
Yeah, but it's really just lunch.
Let's see, well, what did you have for lunch?
The usual. Salad with dressing.
Well, your pulse is 110 and your respiration is 22. When did you start to feel ill?
About an hour ago.
And how do you feel now?
About the same.
Are you taking any medication?
Blood pressure stuff.
Have you taken any today?
I took it at lunch. I just started a new prescription.
Do you have the prescription with you?
Yeah.
Carrie, have you been doing any exercising in the last minutes before I came in?
No.
Well, your pulse is racing, you're breathing heavy, and you're cold and clammy. As a precaution, I think we should get you checked out.
I don't think it's anything.
I'm sure it's not, but just in case.
Okay.
Yes, can you call the emergency response team to Carrie Tull's office? Yes, he's feeling more than mildly ill. No, I'm okay here. Just make sure you bring them back here as soon as they arrive.
As an emergency responder, you play a crucial role in a medical emergency. Your primary response skills make you the critical first link in the chain of survival that summons emergency medical aid and monitors the patient's lifeline, providing aid that increases the chances of survival or revival. In emergencies that are not immediately life-threatening, you provide comfort and reduce the risk of permanent disability.
Your emergency first response secondary care skills can benefit patients by alerting medical personnel to conditions that need attention, by reducing further injury and by increasing patient comfort. As you've already learned, few emergency responders ever need their skills. But if you ever do, you'll be ready to reach out and help another in need.